disclosures, 4 points. This is the last talk of the day, so I'll try to be quick. The changing face of treatment, and then we're going to look at long-acting new preparations, oral, intramuscular, and implants. So 3 different areas to target. The changing face of treatment, and we've dealt with this in a sense today. When you look forward, which is what we're going to do in this talk, we can also look back. And when you look back to see where we've come from the discovery through monotherapy, triple drug therapy, single tablet regimens, through an integrase era, 2018, we now project forward. There are new drugs, which is great. There are the 2 drug regimens, which we've just been hearing about. And we have new delivery systems. So this is something which we do have to think about because it's going to happen. We will have new delivery systems for our antiretrovirals. So please remember there is still a pipeline of new drugs coming through. Recently approved, we've had iberdomide, the monoclonal antibody. And in China, there's been albuterol. And of course, we've had bictegravir as well approved. And then you go down through phase 3. Doravirine will be approved sometime in the next maybe 2 months or so. And we then look at phase 2, phase 1, 2. There's a pipeline. And so let's still be excited about HIV, that the end is not. With HCV, DAAs, maybe there are going to be no more. But with antiretrovirals, we still have new drugs coming through. And this drug, we're talking about long-acting. So here's a drug, iberdomide, which is in a sense long-acting because when you look at the dosage and administration of this FDA-approved drug, it's administered intravenously as a single loading dose, followed by a maintenance dose every 2 weeks. So that's long-acting, isn't it, in terms of what we're thinking about the drug only being given, but it's intravenous. And this is for a very select group of patients, those who are highly experienced, and it will have a very niche location for the drug. And then the 2 drug regimens, which clearly Pedro has been taking us through as you look through the paradigm of 2 drug regimens. And the kind of regimens that we've talked about, from my perspective as a pharmacologist, I want to know for a 2 drug regimen, something about the forgiveness of the regimen, the balance of the 2 drugs that are in the regimen, something about the penetration of the drugs into tissues, the drug interaction profile, and as Pedro said, the use in pregnancy, in renal impairment, in chronic hepatitis B, in patients with high viral loads and past treatment failures. So there's a lot of different issues that we need to be able to fill out this chart with different regimens for 2 drugs and have ticks and be able to be happy that we're fulfilling the criteria for a 2 drug regimen. So let's then go on to the new developments. What are we going to see? What is happening in this area? Is there anything happening with oral drugs? Well, there's a lot of interest in nanoformulations. I don't want to go into detail about what nanoformulations are, but actually the intramuscular drugs that we're using are nanoformulations. It's a way of getting the drug into a different delivery form. And so we have lipid-based nanoformulations, we have polymer-based nanoformulations, and we have other types of nanoformulations. Now, in many centers, there's an interest in, can you improve the formulation of an oral drug so that you could give a lower dose of that drug, therefore saving monies because you're not giving as much of the active product. So nanotechnology can reduce drug costs. We've done a paradigm type of proof of concept study in our center with nanoformulations of lopinavir and efavirenz, which allows a 50% at least reduction in the dose of those 2 drugs. And the potential cost saving, if you took this forward and said those 2 drugs could be used, is around $250 million in the actual amount of the drug that you would use. So this is a form that you can use nanoformulations of oral drugs. And this is the design of the study. It's a study which is ongoing and will be reported within the next 6 months or so. And you can see some of the doses that have been used in these healthy volunteers. There's nanoformulation of efavirenz, 50 milligrams compared to 600 milligrams in one arm. There's 200 and there's 300 milligrams of efavirenz. But there's also lopinavir without ritonavir. So trying to get a formulation of a protease inhibitor without a booster, simply to get enough of the drug into the bloodstream. And so there are different arms. So lopinavir here at 200 milligrams without ritonavir, which would clearly offset the whole issue of drug-drug interactions with a booster if this proof of concept works. So you have this 10-arm healthy volunteer study with all these different arms, which should report in early 2019. And we're awaiting the data, and I think it will be quite an interesting study. The other oral new process that's happening is this special type of star. Now, I think it's hard to understand what that is. Think of a capsule, any drug capsule. You swallow that capsule, and once the capsule gets into the stomach, then it explodes into 6 different arms. Okay, so the capsule breaks open into 6 arms, and in each of those arms is a drug. So you have a triple drug combination, and you have the drug, 1 drug, 2 drugs, 3 drugs, but you can also have different formulations of the drug so that you have an immediate release to give you the absorption to get enough drug in straight away, and then a much slower release of the drug in order to maintain the concentration. So this is a proof of concept which is being done at the present time in animals to get different amounts of drug into the bloodstream over an extended period. I think it will be quite interesting to see how this projects and whether this in the next, sorry, if I just go back one slide. Can I go back one slide? Yeah, okay. So what you can see here is development of a once-weekly oral drug delivery system. So at the moment, it's a once-weekly oral delivery system of a triple drug combination. So that may be interesting if patients want an oral drug once a week, and maybe we can get it once a month. But that's ongoing. I think we're more familiar with long-acting intramuscular formulations. And we've seen already today the attraction of an intramuscular with infrequent dosing. We can reduce the drug dose and overcomes adherence, etc. So that's something we're going into. A lot of interest. Just look at the literature in the last couple of months. Long-acting antiretrovirals, where are we now? Treatment and prevention with long-acting antiretrovirals. Rilpivirine for prevention and treatment. Nanoformulations of dolutegravir. Okay, nanoformulated dolutegravir already being looked at in rhesus monkeys. And towards a Maraviroc, I'm not sure where we use that, but a long-acting Maraviroc as well. So there's a lot of interest in long-acting drugs with many, many of the different drugs being studied at the present time. The most studied is, of course, cabotegravir with rilpivirine, and we've heard about cabotegravir and rilpivirine today. These are drugs which orally are well matched when you give them orally because of their half-lives. Cabotegravir orally 40 hours, rilpivirine 50 hours. But when you give them long-acting, the half-life of cabotegravir is 20 to 40 days, and rilpivirine is around 30 to 90 days. And we have the LATE-2 data, which we've touched on today. And you know about the LATE-2, which is a switch to cabotegravir long-acting and rilpivirine long-acting for maintenance. And patients who started out on the oral formulation of cabotegravir with abacavir 3-TC, then switched to 2 different arms with cabotegravir, rilpivirine, compared to continuing on the oral formulation. And the data, of course, is very encouraging when you look at patients below 50 copies, both at week 48 and week 96. This is the 48-week data. This is the 96-week data. And then you look for the 8 weeks and the 4 weeks. And you can, I hope you can see that the long-acting is actually very promising indeed, potentially versus the oral formulation. So you do have some encouraging data from LATE-2. And again, patients' perception, patient-reported outcomes. Patients seem to like this, particularly the 8-week, which is the rating scale, very satisfied, 6 versus not very satisfied. So here, this color clearly shows that patients were more satisfied than with the long-acting than they are with the oral formulation. So that's very important as well. So we do have some encouraging data from the intramuscular. And the pharmacokinetics of cabotegravir and rilpivirine is also very good when you look at the cabotegravir plasma exposure compared to the target is this line here, which is the oral. That's what you'd like to be in. So we're pretty close to the oral, both for the cabotegravir and the rilpivirine with the 4-week and the 8-week. But, and there's always a but, isn't there? That somewhere we have to think about what happens. Is there failure? Well, in LATE-2, there was one subject, subject 551, with week 48 protocol-defined virologic failure. But this does seem to be related to low plasma exposure. So the green line here, the green line here is the cabotegravir concentration, which was below the median. So in this one patient, the cabotegravir initially seemed to be very low. Now, whether this was an injection issue, and also the rilpivirine was lower than the median. So in this protocol-defined failure, you can see that there was an issue. So that is something we have to bear in mind. The other thing that we need to bear in mind is that there was interesting data from an early study with rilpivirine long-acting PrEP. And that was a patient, and this was in the London study, which our team was involved with. There was selection of rilpivirine-resistant HIV-1 in a patient, in a healthy volunteer who received 300 milligrams of rilpivirine. Now, it's quite a complicated slide, but it's getting towards the end of the day, Tanya, and I keep doing it wrong, so I'm sorry about this. You know, it's just one of those things, you know, you press the wrong buttons and so, I will press the right button eventually. I will, I promise. So what you have here is the rilpivirine plasma exposure in a patient who had an intramuscular 300 milligrams, in a healthy volunteer who had 300 milligrams. There was then a reported exposure to HIV, and you can see the HIV viral load rapidly rise. This is in a healthy volunteer on a PrEP study, okay? And the emergence in that patient of a K101E virus. So clearly, as the plasma exposure of the rilpivirine declined in this healthy volunteer, then there was an exposure to an HIV partner. You can see the HIV and this K101 emerge, which was something that was concerning. One of the things we've also noticed is the huge or the long time for rilpivirine to be removed out of the bloodstream. We saw this from a study that we did in Pittsburgh with Ian McGowan's group. And with that group, we had a cohort of subjects who were involved in a rilpivirine study, and then they were consented for another study over a year later, okay? These were healthy volunteers. The rilpivirine was still present in many of those subjects. So this is time, 600 days. So that's nearly 2 years after a intramuscular dose of rilpivirine, you could still find rilpivirine in some of these subjects, nearly 2 years after the dose, Okay. So that is something that we have to be concerned about, that long tail for rilpivirine in these subjects. The other thing that we need to know about is drug-drug interactions. How are we going to monitor drug interactions with long-acting preparations? Because, for example, in TB patients with rifampicin, it is different because rifampicin has an effect on enzymes and transporters in the intestinal tract for an oral drug, but for an intramuscular drug, it's only the liver which is involved. So will the magnitude of an interaction automatically that you find from an oral study be the same as an intramuscular study? And the only way I think that we're going to be able to do this is by modeling. So this was a study from CROI this year, where there was modeling of cabotegravir and rilpivirine in the presence of rifampicin to try to work out what the drug interaction will be. And certainly the FDA are going to accept, I think, this type of modeling approach for drug-drug interactions with long-acting preparations. So some of the key issues for long-acting: which drugs can be combined, the injection volume, what about misdoses, this long level that you see at the end of a dosing interval, the need for an oral lead-in, which Pep talked about, and will drug-drug interactions be different? This is clearly very important for us. But one thing I think is interesting, you can save a lot of drug by this sort of approach. So let me just imagine that you're having a regimen, oral regimen of dolutegravir, abacavir 3-TC. That's how much drug you take daily for an oral, 50, 600, 300. That's 346 grams of drug a year, which if you take that for 50 years, you will take 17 kilograms of drug. 17 kilograms of drug with an oral formulation of dolutegravir, abacavir 3-TC. Now, if you take cabotegravir intramuscular plus rilpivirine intramuscular, which is here, 400 plus 600 every 8 weeks, in a lifetime of 50 years, it's only 300 grams of drug versus 17 kilograms of drug. It's a lot less drug, should be cheaper, you know, and that's going to be saving money. So that's another thing to think about, the yearly intake of your antiretrovirals. Finally, implants. Implants are used, aren't they? So implants are used. Contraception. Just think of contraception. This is in Chad. This is in the Democratic Republic of the Congo. More than 50% of women's contraceptives are implants. And injectables. So implants and injectables are used for contraception. I'm not sure what the figures are in Brazil. Somebody might be able to say what the figures are for Brazil for injectables and implants. So implants are used. Can we use implants for HIV? Well, these are the little things that are being thought about. This is an implant which is about 1.5 centimeters long, containing the drug. There's another device which is also being studied for TAF at the present time. The potential advantages over injectables is that you can remove it, so you don't have to wait. If there's an adverse reaction, you could remove it. More consistent drug release, could remain in place for 3 years or even 5 years with that implant in place over that period. Of course, there are disadvantages. Specialized device required for insertion, the removal, is there stigma associated with having a little lump where the implant is? Well, these issues are issues that we have to discuss. But the MK8591, which has been referred to several times today, this nucleoside reverse transcriptase translocation inhibitor, is clearly a very exciting drug. It's a drug which is being studied extensively preclinically, early clinical development, and there is very, very good data, I think, for us to think about. So in the early studies of the oral form of MK8591, the dose was 10 milligrams, and over a period of a week or so, you can see the drop in viral load after a single oral dose of 10 milligrams. That dose has now been reduced to 0.5 milligrams, and you get a sustained viral drop with 0.5 milligrams. Now compare that to 600 milligrams of efavirenz. This is 0.5 milligrams of a drug, giving us a drop in viral load of more than 1.6 logs. So that's an exciting development. It's being studied as an implant, particularly at the present time. It's in non-human primates, and you've got a greater than a half-year extended release from formulations of the drug in the rat and from implants in non-human primates. And the non-human primate data is here, showing the plasma concentrations remaining high over a half a year with that implant. So going forward, I think there's a lot of interest in the implants. And this was a paper published just last week of the extended duration of the eluting from the implant, different formulations of the implant. This is in non-human primates, so you've got lots of different formulations. So trying to improve and get the longest half-life that you can of the MK8591. So going forward, yes, there's a lot of excitement. The final thing that I think is even more exciting from my perspective is a little patch which you can put on the arm here. So this is a patch, and underneath the patch there's microneedles. And so those microneedles, which are shown here, clearly they look big, but they're tiny. These tiny needles from the patch, and the drug elutes out of the needles into the arm, and you can get extended release of drug from these microneedles. So I think that's an exciting sort of approach that may, over the years, give us very interesting data. We've modeled, and this was again at CROI this year, we've modeled the release rates of cabotegravir and rilpivirine. So rather than give cabotegravir and rilpivirine by injection, which you get injection site reactions, you can actually get it through these microneedles. And we've been able to sort of look at the way that the drug works, and we think monthly administration is certainly possible, and maybe 2 monthly administration with these microneedles. So I think going forward, we can transform aspects of HIV treatment with nanoformulations. And there's a lot of interest in this approach. Where will we be in 3 years? I don't know. In 5 years? But I do think some of these formulations will come through into clinical practice within that kind of time scale. And with that, I think we have to look at other diseases: TB, hepatitis C, hepatitis B, malaria, and Ebola. I think all of these infectious diseases, given this is an infectious disease meeting, is potential for long-acting and these types of formulations. And with that, I'd like to acknowledge colleagues and thank you very much. And I'm sorry about the...
David?